Hi, everybody. Welcome, friends, back to another episode of the ASAP Pathway podcast. I am your host today, Dr. Stacy, and I am a little giddy to have my friend on today. My friend and local colleague, Dr. Jonathan Shanker. Welcome.
Well, glad to be here. We've known each other a long time, and we've talked about doing this for a while. So I'm glad it's finally happening.
I agree. It's kind of surreal for me. We've been talking, gosh, how long have we known each other? I was trying to think about that the other day because we
It's been a long time. So uh, my son Sam, who was like my kind of airway experiment, you kind of guided me through. He's 14 now, so he was probably around 6 when we started talking airway. So it's been some.
Yeah, it's been some time. We both went to the same dental school. I mean, you were a little ahead of me in dental school, and then you went to New York for your ortho residency, and then you came back to St. Louis. I'll get into all that in a second. Let me just introduce you for those who don't know you like I know you. This is very abbreviated about Jonathan, Dr. Shanker, born and raised in St. Louis, a BA in psychology, summa cum laude from Boston University in 1996. He got his DDS with distinction from UMKC, member of OKU, published research on TMD in 2000, orthodontic certificate and masters of oral biology from the University of Medicine and Dentistry of New Jersey in 2003, joined private orthodontic practice in 2003 to today. So we did land, like, I got out of dental school in 2002. So, like, you joined back in St. Louis the year after that. I mean, we have been connected for over 20 years. I mean, really.
100%. Yeah.
So, um, and it's funny, just I was just saying this in another podcast, you're educated in dental school. You're educated in your ortho residency if you decide to go on to a residency, but the stuff we're talking about today, you really have to dive in and just learn in addition to you learn enough to kind of not hurt someone, right? When you get out of school. But all of that experience, you have to just practice. You have to get out, you have to see the patients, you have to, you know, um, really decide what your passions are, what you're going to do, what you're not going to do. So, all the real learning, I think, comes after school.
Oh, yeah, for sure. When it comes to the stuff that we're talking about, when I was in my residency, we didn't airway wasn't it wasn't even talked about, So we are there for 3 years, and that wasn't a topic of conversation. And I didn't really get into it until, as I was saying, my son, who's now almost 15, so he was probably about 6, um, and he was snoring, kind of gasping at night, and just being an orthodontist, we weren't really airway focused per se at the time, but we did work with myofunctional therapists. We're very aware of tongue posture, and we were doing expansion even back then. But it wasn't for airway. It was
Right.
just to make room for the teeth, and and basically myofunctional therapy for stability. Um, but when I was talking to you about Sam, you were kind of like this whole source of information that I was just hadn't been exposed to. Um, and I remember you told me that we should have a sleep study. Um, and my wife took him to an ENT, and the ENT just wanted to do tonsils and adenoids when he was about probably 4 or 5. And again, at that time, I had no idea what was going on in the airway world. And there was no sleep study. I didn't know that that was even something you could do. But I was like, I don't know, is this what he needs? Let's send him to an allergist because I think he has allergies. And we went to the allergist, and they put him on allergy meds, and he stopped snoring. Um, and he seemed better. And I was like, all right, we got this under control. And I talked to you. You may not even remember it so many years
I
ago, and you
do.
were like, oh, do the sleep study, do the sleep study. And that's when you connected me with Dr. John Smivey. And I was like, okay, I'll do this mostly as a learning process for me, but I don't think he has any issues anymore. So we did the sleep study, and it came back that he had sleep apnea, and they recommended tonsils and adenoids. And I was like, well, I had heard about tonsils and adenoids, a couple of years ago from the ENT, but now we got, data supporting that this needs
Right.
to be done, even though he wasn't, obviously snoring anymore. So then we did that. And that's when the dive started. We were already expanding his arches at that time, but it wasn't because he had an airway issue. It was because he had really narrow arches. Um, so my thought on crowding, orthodontics, airway, has evolved over the years. Um, but what really hasn't changed is, we see all these crowded kids, and they're crowded not because their teeth are large, but it's because they have narrow arches. And they have narrow arches because their tongue's not in the right spot. So, the upper jaw, going back to growth and development, it just grows differently than the long bones of the body. It's intramembranous versus endochondral growth. So you need the tongue in the right spot to get the arch to develop. So that we've always known, and that's why we do expansion and myofunctional therapy. But the airway concept behind it was always lacking. But through our conversations and Dr. Spivey and discovering more with my son, that was kind of the beginning of the journey.
You know what's interesting, Jonathan, is well, and the reason I was on the journey is my own kids. And I think you find, especially in the dental sleep medicine world, it's an orthodontic, airway minded perspective. It's our kids a lot of times that are our greatest teachers and really make us question, do I really know all there is to know? And when you see your child having some obstacles in their growth and development, potentially, neurocognitively, you'll do anything you can. I was doing things in my practice I wasn't doing on other kids, but I did it on my kids because I wanted to see. I was willing to do it with my own children. I think that's the common thread with a lot of people that get into this is, oh, they have a grandson or granddaughter, a niece, nephew, a kid, a neighbor, or a hygienist son or daughter. It's something where you're pushed to maybe consider stepping out of a paradigm that you're used to. Um, and like you said, we're doing orthodontics, we're doing dentistry. It's stuff we've been doing, right? It's just maybe do we do it earlier? Maybe is there a different way to look at it to make room for this tongue to intercede earlier, just neurocognitively than maybe we would wait to do. I mean, you can expand at any age to a point actually, but why intercede so early? Why jump in so early? So um and even just with the extraction orthodontics, knew I was like very much about, can we just please, I mean, it's a more beautiful look if possible to have a fuller face, but it's like if I could just have as much room for that tongue as possible, and um I think you'll talk to orthodontists that have been expanding and they will tell you decades ago that they would expand and they would have side effects sometimes of, wow, the parents came back and told me that, little Johnny isn't snoring anymore. And it's like, huh, what is that? Because we weren't talking about that stuff back then. So it is interesting. And I've always appreciated our conversations because people will say to me, how do I find an orthodontist to work with, that someone that's willing to maybe see kids earlier and maybe be open to having conversations, learning with me, maybe going to different courses with me. And I mean, I've been talking to you and other orthodontists in town for, I mean, it's hard to believe, almost 2 decades, but we can't be that old. But I think it's just respectful conversation and knowing our limitations, knowing that we don't know everything. So, like, from your perspective, you would sit down with me and I would be all, hyped up after an airway course or something. And I would be like, we got to expand. We got to get to these kids early. And what were some of your like maybe not reservations, well, maybe reservations. Like, what were your thoughts? Like, it's not that you said this to me at our most recent lunch. You're like, Stacy, it's not that I didn't want to do it. It's just I didn't know how to accomplish what you were asking, or I didn't know how to accomplish it within, growth and development and with the tools I have in my hands, like to get to that point. And then you said
Yeah.
resetting.
So I think that's right. Over the years, the way that we practice has really changed. Um, but I think there's some natural conflict between the airway world and the orthodontic world, and I wasn't aware of that until I started this journey with my son. And we'll eventually get to my daughter because her journey was where I'm at now, with how we practice for young kids. But so with my son, we used Schwartz appliances to create some space, upper and lower. We did expanders, lip bumper, um, and then eventually phase two with aligners. But the difficulty with some of these appliances is you really don't know how much expansion you're going to get. It's easy to get uncoordinated. If you're going to try and use some brackets and bring the upper incisors forward, many times they'll tip forward and they start to procline. Um, so, the airway world, wants expansion and incisors forward, but the orthodontist doing it, I think sometimes it's like, well, how can I get that much expansion? And if I bring incisors forward, they're going to tip too far forward and that won't look right. So I wasn't even aware of these conflicts until I went to, I think you're the one that recommended it, but it was the second annual sleep medicine combination with orthodontists or dentists and physicians, and this was in Boston. Um, and when I went there with my orthodontic partner, Dr. Schluter, we sensed on that first day that there was like a friction or something. When we said we were orthodontist people, they were like, I'm like, what's happening? Like, they don't seem to be like,
What just happened?
what is going on? So that was like my the first intro to that. There's friction, but I think the friction is just those providing the care have limitations, and those that want airway things, want what they want, but maybe we don't know how to or have the skill set to get what you want. Um, and sometimes we can, sometimes we can't. But what I know I have found over the last few years is that I usually can now. But so the percentages of success as far as taking really, really crowded kids and treating them non-extraction in a relatively easy way um, is pretty high right now. But it wasn't that way 5, 10 years ago. It was, let's try the expander, let's get some brackets, and then if they're too proclined, I can't leave a kid, with their teeth sticking out of their head. So my
Right.
teeth. But with the newer ways of doing it, I feel like we're pretty good at expanding, bringing incisors forward, and not removing teeth. I feel like our abilities nowadays have aligned more with the airway world.
Yeah, I remember you text me. You're like, I really want to show you these cases. When can we get together? And then I think I had to cancel or something. And you're like, okay, let's really get together because and I was like, oh, he is really excited. And I got to reschedule this. And I was so impressed with what you were showing me. I was so excited. And of course, I have this, oh, I wish I could go in a time machine, go back to when my kids were really little and start this process, because I love your process, which we'll get into in a little bit, because it's aligner based. Is that correct?
It is. It's a liner based. You know, with my other, I've got 4 kids, but my she just turned 11, but when she was, and she has the teeth of like a 14-year-old, she's like very dentally advanced. But she had severe crowding. And my wife's entire family has a big begonia on there. Their chin's kind of noticeable. And so, I really did not want to treat her with extractions, but when it's your own kid, I'm showing it to other orthodontists and everyone's like, there's no way you're going to make room for all these teeth. Um, and I'm like, I know, but there's got to be a way.
You're
there's got
like,
to be a way.
watch me.
I wasn't sure either. But Invisalign first came out in 2018, and we played with it back then, and we had some cases going. But there's like anything new, there's a learning curve. We treated, regular Invisalign cases, a lot of teenagers. We treated, thousands over the years, but not many young kids. Um, but I understood the platform really well. I've been using Invisalign, since really as soon as I graduated, so over 20 years ago. So it could take those concepts and put them to kids, but kids are different, right? They expand differently, they respond differently to treatment, their jaws are still developing. Um, so it was the only mechanic that I thought was possible to treat her non-extraction. So all of her canines were blacked out. So she had about 15 millimeters of crowding per arch,
Hmm.
um, and more of a concave profile. And I kind of knew how she was going to grow. And I was like, man, I do not want to take teeth out on her. So I set up the ClinCheck, learned a lot through her case, and it didn't take long, maybe about 6 months into treatment, to realize that it was working and that she could be treated on extraction. So I was like, oh, I'm onto something here. And so that was several years ago, but that was kind of the beginning of, well, gosh, if I see these kids early enough, I've got a mechanic to control the expansion, control the incisor torque, can even control the molars, the torque on those during expansion, upright the curve of Wilson. I can set it up all digitally. I, spend hours and hours a week on the computer. It's actually the most fun part of orthodontics for me, is actually on the computer. It's like the mental game of,
Hmm.
mechanics and attachment processes, and how much extra torque we need here and there. So it's a more fun way to treat. The results that we're getting are, you know, in a different category of what we're able to get before. And the patient experience is easy. They don't need separators. They don't need bands. They don't get the
Oh.
calls about wires poking in, the middle of the night. So it's been a better modality, really all the way around.
Well, and also I was curious, and I can't remember if I asked you this at lunch too that day. And I mean, there isn't any research yet to say this or support this, but there are theories based on just what others have seen. Just talking with Audrey Yoon, like the younger you get in with these aligners, sometimes the softer the child, the bones are more malleable, especially in the really littles. Like, I mean, geez, she's done some ClinChecks. I've done some Invisalign on 3 and 4 year olds just to get them out of these crazy crossbite. I mean, and they just open up, and it's like, are we getting some skeletal changes too, possibly, in these younger
Yeah,
children?
yeah.
That's
I think we definitely are. In fact, at that airway conference in Boston that I went to, we were already using aligners, but I wasn't sure you can get skeletal expansion. I remember talking to one of the docs there about it. Um, but we've known since I was in my residency, that a removable Schwartz appliance could get skeletal expansion on a young enough child.
right.
Uh, so I think the concept, mentally, that where I'm at right now is, you can never really expand the lower arch skeletally, but you can upright the curve of Wilson.
Hmm.
And on a young kid, it doesn't take much pressure. I mean, on a healthy kid who's 6 years old, their tongue is going to expand their arch quite a bit. So I consider the aligners essentially an artificial tongue on the upper. And there has been research that to show that you do get some skeletal expansion. Um, so, I mean, and I have more cases to show you, because every week I'll see new cases coming in. And what I'm seeing now, which is kind of exciting, is so we'll get, really good expansion, good incisor position. And then watching the premolars come in, premolars usually come in, especially on the upper, wider than the primary teeth. So they're coming in, and they're bringing, the bone with them in a spot that wasn't even there before. I'm seeing, lateral incisors on upper laterals on an X-ray that you can see they're really rotated, but by the time they come in, they're straight. So I'm like, was that more stable now because the permanent tooth is erupted in a straight position? It would make sense that it would be. I think there's so
Right.
much more to learn, but I would never go back. I almost feel guilty when I see some of my older patients come in. I'm like, oh gosh, I don't say it out loud, but I think I would have done
Right.
this differently. What I know now with the tools I have now.
No, I think we all, I mean, shoot, if I could go back and have someone treat me, I'd be in a totally different situation than I am right now. And Same with my brother. But again, we only do what we know and, what we're taught in school. And it does take some fortitude to step out of a paradigm and do something very different. And like I said, it's easier to do it when it's your children or a niece or nephew, or, someone's asking you, please, do something unique. Let's just try this. I know it might not work, but let's just try it. It's like you have to have enough of those, which is the point. People want, like, where's the research? Where's the research? Well, I think we're in the most unique time right now with this whole, airway minded, airway friendly or airway aware, just being aware that there's an airway behind the arches that we're working on, and being aware of the TM joints, and being aware that the palate is the base of the nose. I mean, we just need to be mindful that we're moving a lot of parts in the face that affect other areas. That's just logical. And we are in the trenches, like we are developing the protocols as we speak. So, to say, well, it's not evidence based, what you're doing is not evidence based. And part of evidence-based medicine is actually, it isn't just research, it's also, what are you seeing anecdotally in your practice? What are the patterns? What are other doctors seeing? That's why it's the practice of medicine. We all talk, we go to lunches, we share cases. Like, I've seen this more than once. I've seen this. And from those patterns, then we can say collectively, let's research this, So, but if you wait for research, it's just never going to happen. So, um, sometimes the people that stand on the hill of, I'm not doing anything without the literature, well, then you're not helping a lot of people, I think, because you've got to, use your doctor mind, do no harm, um, collaborate well, and see what's working in other people's practices, which is what I'm excited about with you, is you've started to do just that. You're so excited about what you're seeing in your practice. No one taught you this. There's not literature on this right now, really. But what you're seeing with your daughter and other patients now, that this is the standard of phase one treatment now in your practice, you are sharing this with other orthodontists. So if you could share, like, your journey on that right now.
Um, yeah, like the so when you start doing things differently. So I've been practicing orthodontics for, I think it's 21 years. Um, and I joined my dad's practice, and my dad was always ahead of his time. And really, his clinical practice, he's still practicing. Um, doesn't do the aligner stuff, but he's still practicing on our braces patients, and our other phase one mechanics. But so he was way ahead of his time. But in my residency, I didn't really learn much about phase one, and most people don't. And I think the reason they don't is most of our patients are not children.
Mm-hmm.
So the research is never going to really come out anytime soon, because the research happens at universities, not in private practice. So if you don't have the patients, and you know, no one's doing, as far as I'm aware, of what we're doing in universities. So when is the data going to come out? I wish, I keep thinking that teaching would be fun. Gosh, what if I, at some point start teaching, and then we start doing research on this? So who knows? Maybe in 10 years I'll be the one helping with research on this. But the research is definitely lacking. But ortho to me has always been, it's an art, a science like dentistry, but people do it so wildly differently.
Yeah.
Uh, so it's almost like, gosh, is this a science? Like, why do some people do it 100% different than others? So there's a wide variation. When I was in my residency, I knew I was going to be joining my dad's practice, and I didn't just want to take from him. I wanted to bring stuff. So I would travel to, and my school is very kind to let me do this, but I would travel to well-known orthodontic offices and try to learn different techniques and different things. Um, and so I was, gaining information, but none of it was phase one. Like, all my phase one I learned from my dad. And those mechanics works. It's basically expansion and lip bumpers and those kinds of things. But in today's world, the 3D printed appliances and knowing how to work computers is probably the key. I feel like Richard McLaughlin is an orthodontist that I really admire. I used to visit his office in San Diego. And when I was in my residency, in his book, it said the best orthodontists used to be the best wire benders.
Mm.
He said now it's the best bracket positioners. Um, and I think that was true 20 years ago. Um, and it's still, to some degree, probably still true for some braces patients. But but I think it's really morphing into the best at computer stuff, understanding growth and development limitations and how to manipulate software on a computer. So I think staying aware and updated with current trends in orthodontics is it's just 100% different than what it was, even 5, 10 years ago.
100%. And even to just imagine what it's going to be like 10 years from now. I just had this conversation. Well, I didn't just have this conversation, but I keep having this conversation over and over again about the literature and the research. And, there are, you know, the orthodontists that come on the podcast, they say the same exact thing you just said. There isn't a lot. When we come out of ortho residency, we really don't have a lot of experience with phase one, which was so shocking to me when I heard that. But it makes sense because the majority of students, or I'm sorry, patients seeing students in ortho residencies, they're in that orthodontic age range, right? Like, I'm sorry, braces like phase two, they're kind of 12, 14, they're ready for orthodontics, and um, it sure is affordable to go to the orthodontic school, and you're going to get great care. It's just you're going to get great phase two. You're not seeing that population of 4, 5, 6, 7 where things are. I mean, just gosh, it would be so great to get that population into the hands of people that could see what we're seeing and go, oh my gosh, we need to really study this, because the changes you can make in that child at 5, 6, 7, 8, like it's so impactful, even just neurocognitively screening them, getting them to an ENT. Maybe they do need a sleep study. I mean, because we do have to ask the question, it's like something caused the hiccup in the growth and development. Something caused the tongue not to be in the proper position. The tongue is nature's expander, and when it's not in its house, growing the bone like it should be, why? Why is it hanging low? And why are, maybe they're mouth breathing, maybe they have allergies, maybe, it's like, and that started somewhere. Like if we can get to those kids when they're younger and just change the trajectory of that growth and development, it would be so great. So maybe Jonathan, you will be, hopefully, I'm, I will be like, I knew him when. Maybe you
Yeah,
will be
well,
part of research.
we'll see what happens, but I like what you said about why is this child crowded, um, and as we were talking right before the podcast, orthodontists know it's not due to big teeth; it's due to narrow arches, and we know that the narrow arch is due to the tongue posture. So why is their tongue low? Is it because they can't breathe through their nose? Is it low muscle tone? Is it habitual? We have to get to the why to know, all right, will expand, but do they need to go to a myofunctional therapist? Um, do they, do they need to, is there something behind it that they need to go to a sleep medicine doc? Should they have a sleep study? So there's, yeah, if you don't get to the why, then you're probably going to get some relapse if the tongue is in a new spot.
Right. You won't have the stability, and you haven't really addressed the why behind all of it in the first place. Like, and it's important. The anatomy is important. The mechanics are important. How we accomplish, trying to get that patient to where we think they would have been. Like, what is their norm, and that's the other thing, there's a lot of, people out there that want a certain intermolar width on everybody and this and that. And you know, uh, this is what the profile should be, really. And when I was talking to Rebecca Bacow, and Michael Gunson, they have a really great course, airway minded course, oral surgeon, orthodontist. Um, and it's interesting if you find what, sometimes the most beautifully aesthetic face is also the most healthy face for that patient. So, it's finding the why for that patient. How do I get them off the trajectory they were on and on a healthy trajectory and get them back to where they probably would have been had they not had the hiccup? I mean, it could be as simple as maybe they had a really bad cold or they had the flu when they were 2 or 3 and they started mouth breathing and then it became a habitual situation and they never, because you can really develop nasal disuse and the nose almost turns off and they don't know how to turn it back on again. I mean, and they're mouth breathing and it's just, even educating the parents, that this is not normal when you see a child not breathing through their nose, the cascade of events that happen from that, it sounds so simple, but the nose has over 40 different uses, for breathing. The mouth has none. So it's like there's a reason for that, and so they should be breathing through their nose for multiple reasons, but growth and development is part of that. And yeah.
Yeah, no, getting back to my daughter who just turned 11. So I couldn't figure out why her arches were so narrow. I mean, obviously there was a tongue issue, but she didn't seem to have a breathing issue. She seemed to always breathe through her nose. I didn't know why. But I did send her to myofunctional therapy because I was like, this new arch position, which I'm getting, which looks awesome. It's definitely not stable because where we were at before I started was stable. Like that was incredibly crowded and it was stable. Uh,
Hmm.
so if I expand, whatever was causing, the imbalance between the tongue and the lips is going to have to be corrected. So that was my thought process on myofunctional therapy: is if you're going to, change the housing, then you got to, change the muscles, otherwise it might go back.
And we
So
may never know the why. You know
I
what I'm
know
saying? You're right.
sometimes I feel like it now. Now my son, he definitely had some low muscle tone issues. I think, that was his why. But my daughter, I don't know. And the kids with sleep apnea, well, that's the why. Their tongue's low, they're breathing through their mouth. But some we don't know. But I think myofunctional therapy is just an absolutely essential piece when you're changing where the teeth are going in a significant way when you're expanding and bringing incisors forward in a controlled fashion. Otherwise, I'm afraid of, over time it'll be more likely to relapse.
Well, and it's interesting. And the podcast I just did with Dr. Kevin Adair and Nora Sabagan, um, I always say Bogan. I think it's Bogan. She's gonna kill me when she hears it. It's Bogan, Marissa Bogan. But we were talking about myofunctional therapy, and a lot of people. It's a lot of words. Oral facial myofunctional therapy. It's basically physical therapy for the head and neck area almost. The face, this the tongue, and the importance of that. And um, if you had disuse or weakness or compensations in your body, you would see the PT, like, why is this so much smaller and why are the bones different? Well, it's because you don't have muscle there and you aren't using it. So we got to bulk up the muscle and we got to give the bone a job, and the muscle moves bone. And it's no different than with the face. So muscle affects bone. You don't use it, you lose it. So
I
it's like,
I think that's totally right. And I think the old concept in orthodontics is you're not going to change that housing. So if they're crowded by a certain amount, even if they're younger, do serial extractions or just work within the housing that you have because it's not stable or periodontally healthy. And I think with the older tools that we had, it was true. Um,
mm, good point.
So, but now we have tools that you really can, on a young enough kid, totally change the housing in a safe way. So it's different. So now it's like, okay, now we can, but that's a new concept.
Well, and what I like about what you're doing, and I said this, oh my gosh, you handed me photos of her arches and I was eating and I just put my fork down and I'm like, This is amazing. This is beautiful. And how you got her centrals forward without that crazy proclination. I'm like, this is beautiful. But what I was so happy about, I'm like, look at all this tongue space that she has, like, look at these arches, look at this palate. I mean, and the palate change shape. And that's where I was saying, you've got to be getting skeletal changes. It's not just dental alveolar. Like, things are happening
You
and
know,
it's so
it's definitely
impressive.
skeletal, and there is research to show that it's skeletal, but they've got to be really young. You know,
Mm,
they're we have a lot of aligner patients that are 11, 12, 13, and I don't think you're getting skeletal expansion. They've got to
right.
be, yeah.
Right.
I mean, that's why I'm telling referring dentists that the window is really important now, because there are 8-year-olds and certainly 9-year-olds that their primary molars are falling out and it's too late to use aligners. And that's my favorite way to do this. I think it's the most predictable in my hands and it's easier for the kids. So earlier now, the time window is actually really, really important.
So, and then here's the other thing that's beautiful about this is, you're creating space for the tongue, and I think it was Mike Mew. I can't remember, but I want to give credit where credit's due. I think it was Mike Mew, who is John Mew's son, those that are familiar with the popular mewing. But I went to see John Mew 15, 16 years ago, and he had some interesting ideas and concepts. I think everybody might have different ways that they're trying to get there, but I think we all want to get to the same place. Broad arches, room for the teeth. They don't have macrodontia. We just need room for the teeth they have. The arches are constricted, but his point was about muscles. Mike said every muscle has an origin and an insertion point. And the tongue, its insertion point is the palate. That is that muscle's insertion point. And if you do not have that muscle in its correct insertion point, you're going to see just a collapse of craniofacial structures. And I was like, oh my gosh, I've never even heard it that way. Like the tongue's insertion point it's this almost like a crazy suction of sorts. It goes just naturally up in there and it's just pushing and creating a pressure, and it's up and forward and it's out of the airway, and it has tone to it. It's not a flaccid muscle. But, I just love the fact that while you're doing this, creating room for that tongue, that's where I was going. Sometimes I squirrel. Um, these are aligners. So what we've tried to do sometimes in these kiddos is, put in maybe a house device like a HAAS, fixed bonded expander, something to get as much skeletal as we can. And a lot of times it just blocks the palate and the tongue can't get there. And sometimes during that, you actually see kids kind of get worse a little bit because um, it's a necessary thing sometimes to get those expanders in there. But what I've noticed is the designs over time are trying to be more tongue friendly to accomplish skeletal expansion, because we're blocking the tongue from its insertion point while we're trying to help them. But with what you're doing, that tongue space is wide open and it's assisting you, right? So you can get the tongue up there. Are you kind of seeing that as you create more room, the tongue naturally is going up there a little bit more because it has more room? Or what is it helping you along the way? What are you seeing?
As far as tongue posture during treatment, I'm not really sure, but the myofunctional therapy piece, I think, we're hoping that, we'll wait till at least the arches are broad enough before we refer. But, the classic Haas expanders and the other expanders, the the classic problems with them are there's a couple of things. One is it tends to, we're looking for skeletal change, but it tends to tip the molars quite a bit.
Mm.
And so with the techniques that we've developed, we don't really see molar tip. So we don't have anything to correct afterwards as far as torque on the posterior teeth. And then probably even more importantly is where if someone isn't in a posterior crossbite, classically, it's kind of hard to expand unless you upright the curve of Wilson, which isn't the easiest thing to do. And if you do it and don't do the upper at the same time, and it's hard to keep them coordinated, you're going to end up in a crossbite that didn't exist before. So now you can just expand both at the same time, which allows you to do so much more expansion. Um, I was at a lecture at the AAO not that long ago, and the guy was talking about impacted canines and how when they're on the facial, if you expand early, that the odds of them coming in are much higher, and it's true. So he was showing cases to expand into Brody crossbite to help to get the canines in. I'm like, well, that's good, but now how you gonna fix a Brody bite? Like, I've
Yeah.
fixed one problem, we got another. But with the use of I think well applied technology, you can just get it all done in a relatively easy way with minimal side effects. Um, so that's been the exciting thing that we're doing, because you do the same thing for 20 years and starts to become routine. But so this is we're helping kids, we're doing it in ways that are easier for them, and it's kind of fun as an orthodontist to see, oh gosh, this is working out so well. Um, so just a paradigm shift. But I guess in any job, if you're doing it for 2 decades, you hope that hopefully you're doing it differently than the way that you did it 20 years ago.
Right. I've said that too. Like, I don't practice the same way I did. And I hope patients understand that. Like, you really sometimes are like, wait, why are you doing this now? You weren't doing this last time. You really kind of want that with whether it's a primary care or primary care dentist or your orthodontist, whoever's taking care of you and your family. I know it can be a little bit like, wait a minute, what's going on? You're doing things different. You didn't do that with my other kid. And
Oh
there
yeah,
can
I,
be this,
I get that.
yeah, there could be a
Yeah,
little friction there, like, well, why didn't you do it? And it's what people have to understand, and I hope they understand is, medicine is changing and it's a good thing that we're not necessarily doing it the same exact way when we worked on your kid 10 years ago, your other kid 10 years ago. And like, if we could go back in time with the advances and, it's an exciting time to be in orthodontics and an exciting time to be in dentistry and I think medicine. We're just good grief. What's happening with AI can be scary, but also amazing. Um, but the tools we have now, and even the information, like the cone beam. I think back to all I did was panos and the stuff I find every day on my CBCT. I find things earlier, or I'll find, root fracture situations or endo that isn't showing up on the PA, or it's not like we're just seeing things earlier and differently. And, I hope patients understand that with the new technology, we are able to be a little more proactive. Um, and sometimes I'll get that in my practice. I'll get a new patient and oh, you have all this fancy stuff. My other dentist didn't say I needed any of that. And I understand it's a little startling, like, wait, your treatment plan's this, their treatment plan was this, but I'm seeing things differently. And isn't that a good thing? But it can be a little bit, whoa, to a patient with change, or going to, like you said, going to one dentist to another orthodontist to another, you give completely different treatment plans. And it doesn't mean they're a bad or they have ill intent. It's like they just have different technology or they have a different education background or, so it's really up to the patient to kind of do their due diligence and, be their own advocate for what they're looking for. Because Jonathan, as you and I both know, like it's it's the why behind the treatment plan. So, a patient can go to orthodontist A, B, C, D and have totally different treatment plans, but maybe why you're treating and what you're treating is different than their why and what. So, of course, you're going to have different treatment plans, and it doesn't make anybody wrong or right. It's what are you treating? What am I treating? And this was the discussion even with we had a podcast not too long ago, just even on some class 2 situations. So we know that there is an optimal time. So class 2, for those that don't know that, it's when the lower jaw is far back. And there's an optimal time to kind of work with and treat that class 2 during a growth spurt. But if you have a child that's 4, 5, and 6, and they're suffocating from that class 2 in their sleep, everything's falling back. If someone's treatment planning maybe a herp style situation or something for nighttime wear to keep the airway patent, if we're just very clear that, look, what I'm treating is airway patency, I'm not expecting the class 2 correction maybe right now, and yes, we might have to treat that again later. If we could just have more dialogue about that, instead of maybe when another dentist or orthodontist sees that herpst or whatever myofunctional device on a 4 and 5 year old, like, oh, what are they doing? They can't correct that. There's no growth spurt. I know, but I'm not treating a growth spurt situation. I'm treating a child's airway patency right now. And then I will gladly hand them off to you for that orthodontic actual skeletal change later. It's just that's not what I'm treating right now. So, it's about conversations, and maybe pick up the phone and call your local dentist or orthodontist colleague and go, can you just tell me more about your treatment plan? Help me understand it, like where you're coming from, because I want to understand what you're treating and why you're treating. I just think those conversations, respectful conversations, I think we'll learn more from each other and help more people. And I've always appreciated that with you. Is you and I have always been, we may not be in the same place yet, but we are trying to understand where each other was coming from. And now
Yeah.
I'm so excited. Like, you're doing stuff. I am like, oh my gosh, this is fantastic. This is great, and it's your journey. You had to get there on with your own path.
Yeah, I think what you're talking about is great as far as the dialogue and that people see things differently. And there's a natural tendency for all humans to have an ego,
Yep.
uh, and to be like, hey, I'm doing it the right way, and how can someone else do it differently than me? Um, but I'm a human too, but I try to resist that as much as possible. Um, but yeah, I think it's a as far as the orthodontist that I know and the dentist that I know, I mean, we're all working for the patients. Like, we all want to get good results.
Hmm.
So everyone is really trying to get to the same place at the end. Um, but things change. I was saying before how when I started, my dad was doing a lot of phase one, so we were known as a phase one office. My dad was doing passive, or he was doing self ligation. I had self ligating brackets in the 80s, which is like
Wow.
a big thing now. Uh,
Right. But that was so progressive.
that was so progressive in the 80s. So these things come and they go. Um, when I was a younger orthodontist, there was a new bracket system out I was very excited about, and kind of pumped up my ego. I was, on the, with the group of orthodontists that were leading the charge with the company, and they would take us out, and it felt good. We were innovative, but everything in ortho is slow. So after I had treated enough patients over enough years, I started to see all the problems with that design. And I learned the hard way that bringing on something new in orthodontics is challenging. And then if it's a problem, now you've got a bunch of problems,
Mm.
and it may take years to really figure out what those problems are and if there are good solutions for them. So I think there's a natural tendency for orthodontists to not want to introduce errors because what you're doing now works for you. And then there's a learning curve, and what if it doesn't work? And I've been through that. So but fortunately never gave up trying to always learn something better, do better. um, and with aligners it was easier for us because we had so much experience with it. Just the application of kids, that was a relatively new piece, and I wouldn't go back. It's allowed us to do more things that are airway friendly. But I just don't like moving teeth. And I know you probably hate it, but sometimes there are cases I see that I'm like, man, I cannot get these to fit without moving.
Right. It happens. It
It
does
does.
happen.
It happens. But nowadays I tell people, and believe it, that if I see kids when they're young, send me your crowded 7-year-olds, and I feel like, not 100% of the time, but the vast majority, we can get a really, really nice result without moving any teeth. So I feel like serial extraction used to be something that we would do sometimes. Removing primary teeth to help teeth come in, something we used to do. But I just don't do that much anymore. I feel like with the things we're doing nowadays, it's just it's better and it's easy for the kids. So it's like this whole, new concept. But there's a tendency, like I was saying before, to not want to push the envelope because what if it's too far? And that's why we try it on our kids first because we're like, I'll see you every day. If this is getting screwed up, I can always just go with the traditional stuff.
Right.
But I'm willing to do a little extra because you're my kid and I want to see if this works. So I think that's why you were saying before that our kid, we learn a lot from our kids because we're willing to go outside the box for them. With the patient, we don't want to do something awkward. And
Absolutely.
now it's not just one, maybe I got 100 people in an appliance that will find some flaws with. And there's a learning curve to everything. But hopefully at some point technology changes, people realize what can be done, and then ultimately patients get better care.
I would love, I'm going to put some information um in the podcast for how people can find your practice. And there's probably going to be some orthodontists, maybe some general dentists or that want to talk more to you about what you're specifically doing. I know that you've been doing some education already, your journey. Like you said, the door's opening for this to teach the method that you're using within Invisalign First, which is very impressive. I know you've got, uh, do you have a course coming up that's open for people to register for, or is it already closed, or is it able for anyone outside to join, or it's already
So far it's been private study clubs.
got
Uh,
it?
so,
Okay.
and the next one's in Costa Rica. So, that sounds
Ooh,
good.
that
Um,
sounds really good.
right. But I'm in communication with Align to come up with some protocol for teaching what we're doing. So that's probably
Great.
up and coming.
That is fantastic. And you know to please come to me as soon as you get that information. I'll be happy to share it with people so they can learn this technique. It's really, I'm just so happy. I'm so honored to have you in my town. And I tell people, I know Missouri's considered a flyover state, but I think we have some pretty impressive people here in St. Louis that are really leading the way in the Midwest, the show me state, usually everything's on the coast, but I've been really proud of our colleagues here in St. Louis. We're doing some pretty cool things that I think are going to help patients nationally, internationally, and you're one of them. And I just wanted to have a conversation, friends, just about our journey. And because I think there's a lot of dentists like me out there and having conversations, and they feel like, does it really matter to go out to lunch with? It does. I think it does. You need to establish communication. And I feel like COVID kind of shut down everything like that.
Yeah.
And I really hope people start getting back into, or even just Zoom with each other if you don't have the time to do lunch. But I still like breaking bread with you. And maybe it's because we're old.
Well, it's probably time for us to set up a lunch and get together.
It really is. It is. We had a good time last time. That was delicious. Um, all right. I know we got to get going here, but I wanted to ask you three questions. It's like holiday season.
All right.
No matter what the holiday is that you celebrate, I just had three questions. Um, and the first one's yes or no. Eggnog.
Yes.
Ah, me too. I love eggnog. It's got to be super cold though, I say.
First time I had eggnog, I was a little kid, probably like 3 or 4, and it was at Baskin Robbins as an ice cream flavor. And I remember it, and I was
Yes.
like, I liked it.
Yeah, it has a great it's I love the spice to it, but to
Mm.
me it was almost like drinking eggnog is like ice cream it's got to be cold though. Like some people are like that is disgusting. I want nothing to do with eggnog. I mean the name is gross, but
My kids love it. If my wife buys some, it's gone within 12 hours
oh,
usually.
it's so delicious. I don't even want to know what's in it. I think a lot of egg, but it's
Yeah, I don't think we want to know how much
I
fat.
don't let's not talk about what's in eggnog, but I love eggnog. Okay. What is your favorite holiday dessert?
Favorite holiday dessert? Gosh, that's a hard one. But the first one that comes to mind is pecan pie.
Ah. Man, we're 2 for 2.
Are we?
Yes, most
Okay.
yes, pecan pie. I love pecan
And then
pie.
if it's warm and put some ice cream on it.
Yes.
I haven't ever put eggnog ice cream on it, but that sounds really good.
Ooh, it does. I'm thinking of some things, like, it wouldn't be a bad idea to even have eggnog while you're eating your pecan pie.
There you go.
We're probably making some people sick right now. Okay, and then what is your favorite holiday tradition?
Favorite holiday tradition would probably be the Passover Seder. Um, yeah, it's a reenactment of the Jews, leaving Egypt from slaves to free people. But it's connecting with kids, and it's reenacting, and it's been going on for thousands of years, and it's fun.
You know what's interesting? I have heard multiple people that I have friends that are not Jewish that have attended those, and they're like, it is probably one of the most amazing things they've witnessed. And it's powerful and it's family. And it's, again, you don't get any more traditional than something passed down that long. That's pretty cool. Not,
Yeah, it definitely is a family centered experience, which is fun, right? Hey, without
yes.
family, we wouldn't have progressed on our own dental ortho journeys,
That's
right?
so, so true. I
Or
had a
better.
podcast about with Shane, Dr. Shane Creato. He's a sleep physician from the Amen clinics. And we were talking about holiday traditions and stuff. And he was talking about his, and just it all came back to family unit. And unfortunately, the family unit just isn't as strong in this culture as other cultures. So it behooves us to really kind of focus on maybe all of us, if we don't have a family tradition, maybe come up with one this year. Start one.
You know, it's as you're mentioning this, I feel like just popped in my head, but I was at an Invisalign meeting probably 15 years ago, and the guy who invented the iTero scanner, um, he didn't work for. He was used to be separate from Invisalign. Invisalign bought the iTero scanner. Um, we ended up talking to him at this Invisalign meeting, and he's a really fun, entertaining guy. I think his name was Avi. He was Israeli, and and he told me that his kids were all older and married, but he had every year he had recorded videos of them and did an interview with his kids since they were little. And being a tech guy, he's probably using some, who knows what state of the art was, 30, 40 years ago. So ever since then, I've done the same thing. But now it's much easier. Just pull out your phone and store it on the iCloud. So every November, this year it's going to be December. I haven't done this year's yet, but I will next week. We'll have these, annual. Everyone does their video, and it's fun. The kids love looking back at their old videos, which
Do
is
you
just.
ask them the same question? Is
It's
it this?
not some of the same, like who's your teacher, what's your favorite color, what do you like to eat, but just spontaneous. You would be good at it, right? You're the interviewer. Um,
Shoot, I should get on that. That's gonna be
yeah, it.
mine are so old
So
now
that
that
was that was a fun thing that was introduced through an ortho meeting that was a cool tradition that we picked up years ago.
I love that. Thanks for sharing that. You may have just started some new traditions for other people too. That's
Right?
awesome. Yeah, I love that. Well, thank you for being here, Jonathan. And I'll keep everybody updated as your education journey starts. I have every confidence you're going to keep going because I just know who you are and you're very passionate and you want to help people, you want to help patients. And that's why I've always felt so honored to have you in my community taking care of my patients. We had a mutual patient, I forgot to mention this, last week in my chair, and she was, "Oh, I'm seeing Dr. Shanker next week." I said, "Oh, well, I have him on the podcast Friday. So I think she's seeing you Tuesday or Wednesday or something." And I said, "Be
All
sure to
right.
listen to his podcast." So it's just been an honor to share patients over the years and take care of people together. So thank you for
Yeah, I feel the same way. And thanks for having me.
absolutely. Thanks, everybody. And if you're interested in understanding more about ASAP, we have a free ASAP Pathway newsletter you can register for. I'll have it in the link. I'll have info on how to find Dr. Shanker as well. And thanks for joining us. And until next time, see you later.